Center and completed her infectious diseases fellowship at Northwestern University in Chicago. She is a professor of pediatrics at Emory University and the director of antimicrobial stewardship at Children's Healthcare of Atlanta. I know Dr. Jaggi from our small community of pediatric infectious diseases physicians and the smaller community of pediatric antimicrobial stewardship. However, although it's a small community, don't underestimate our effect. So this is a community where change in healthcare happens. And one of the hot topics that we're dealing with now is the issue of healthcare sustainability. Dr. Jaggi became one of the main voices raising awareness around this issue. And I'm sure you will get some eye-opening information from her talk today. And I really encourage you all to take some of the ideas she will discuss and start thinking how to apply them through your practice, no matter what your specialty is. Without further ado, Dr. Jaggi.
Thank you so much for that kind introduction. I'm really excited to talk to you all today about addressing the climate crisis through healthcare sustainability. And I will tell you what these pictures of the Mona Lisa mean towards the end of the talk. So I wanted to talk about my disclosures. I have no financial disclosures. My real disclosures are that I'm a pediatric infectious disease doctor and I'm an antibiotic steward. So I'm going to give you a lot of information through that lens. And I also have climate anxiety, and I worry about the future of my children, and I worry about the future of my patients. I do also find joy and hope in mitigating greenhouse gas emissions, and I hope you can too. And I hope to convince you that practicing and integrating antimicrobial stewardship is a meaningful way that you can be a climate hero. And then finally, I'll give you a framework to analyze what climate actions that you might take. A lot of what I'm going to give you is through the lens of antibiotic stewardship, but hopefully this framework can give you ideas about how you can bring these concepts into the work that you're doing every day. So one thing I just wanted to just start out talking about is this idea of One Health. That's the idea that the health of people is connected to the health of animals and our shared environment. This concept first became sort of raised in the 1800s when we were seeing a lot of connection between zoonotic infections and human beings. And now we're really bringing into this idea of healthy ecosystems that we all depend on. So when we protect one, we protect all of our shared health. And one way that we started thinking about this is with the idea of antibiotic resistance, that the use of antimicrobials in livestock to promote growth also promoted resistance in animals and then also that in humans. And so that's one way that we've sort of integrated this idea of One Health that in antibiotic resistance, because we know that when we excrete these substances into the environment, that can go from one person to the other. And antibiotics are sort of unique drugs in that what we do in one person can actually affect another person distant from that person. So we started making a lot of efforts in trying to decrease unnecessary antibiotics to promote livestock growth. We've also made a lot of efforts to optimize use of antimicrobials in human beings. And this is just over a 10, 15-year period about how some of the efforts that we made to start thinking about antibiotic resistance, using antimicrobials more appropriately, and also thinking about the harms of antibiotics outside of only just resistance, but individual harms to patients as well. And so some of these efforts culminated in having antibiotic stewardship programs at each acute care hospital. And that's the community that I have been a part of since about 2013. So we kind of come up with some different ideas about the 4 critical moments of antibiotic use decision-making. 1, making a correct diagnosis. 2, culturing and using empiric therapy appropriately. 3, thinking about the duration of therapy, the minimal optimal duration of therapy for patients. And then 4, stopping, narrowing, and changing to oral antibiotics wherever appropriate. And when we started thinking about this, we also realized that, hey, we really need to think about the diagnostic aspect of this. If we order the right test for the right patient at the right time, we will also use drugs more appropriately and have better antimicrobial stewardship. And we also need the right interpretation of the test, the right antimicrobial, and the right time. So we started coming up with this idea of diagnostic stewardship. as it pertains to antimicrobial stewardship. So we've made a lot of strides, I would say, in antibiotic stewardship. We have really have decreased a lot of use in hospitals and optimized the way we use antibiotics. And I think that's kind of the platform of sort of how that evolves when I think about thinking about this last part of the Venn diagram of One Health is with environmental stewardship or sustainability. We know that the environment is changing, climate is changing, there's water pollution issues, there's air pollution issues, there's biodiversity loss, and humans and animals depend on healthy ecosystems. So let's talk a little bit about that. Climate change. This is to me the elephant in the room when we think about children's health. Over 200 medical journals on a single day said that the rapidly warming climate is the greatest threat to global public health. They simultaneously published the same editorial. And they say that we risk catastrophic harm to health that will be impossible to reverse. So we spent a lot of time thinking about children's health, thinking about how we can optimize, early detection or treatment. But we know that the elephant in the room here is that the healthy ecosystems that we depend on are changing. What is happening right now in LA to children who've been displaced from wildfires? We depend on a healthy ecosystem. So this is a really, really big statement. And I think it's really easy to respond to this statement with either one of two kind of reactions. The first is just to sort of say, we're not going to think about this. Everything is fine. This is fine. Everything is fine. Everything is not fine. We know that everything is not fine, but it's really hard to think about. And I would invite you to think about it like in the movie Inside Out, where this girl who moves from one area of the country to another area, and she starts experiencing a lot of negative emotions with that move. And for a period of time, her joy emotion, or the little girl in the green dress emotion, starts kind of squashing her negative emotions. And so she really starts making some bad decisions. And I think she had to move through some of those negative emotions in order to be able to make better decisions. So it's important for us to recall and just respect the fact that this is hard and this brings up difficulties, but don't let that stop us because our kids need us to act on climate. So I'm going to just show you this slide from the journal Science, and it talks about intergenerational inequities when it comes to climate. So younger generations are more likely to experience extreme weather. If you compare a birth cohort from 1960 to that born in 2020, the lifetime risk of extreme heat wave exposure on the left-hand side is higher for those born in 2020, and it is higher the more the world warms. So even if we don't reach 1.5 degrees Celsius targets, 1.6 is worse than 1.5. 1.7 is worse than 1.6. So the more the world warms, the more risk of extreme weather exposure we have. And on the right, you can see that for me, born in the 1970s versus my children born in the 2000s, they already have a higher risk of extreme weather exposure. So when we think about climate and equity, we should be thinking about intergenerational inequities. And we know that extreme weather, which occurs in different types of forms, will also have downstream effects. So this is from 2017 when we had Hurricane Maria. 2,900 people died in Puerto Rico as a result of that hurricane. And U.S. hospitals also the mainland U.S. hospitals wrestled with shortages of drug supplies made in Puerto Rico. Fast forward to this year, we know that Hurricane Helene also created saline shortages, and we are struggling in much of the mainland United States because of that. And that was from a hurricane that reached North Carolina. So we know that there are downstream effects that we are probably not accounting for. So let's just take a little quick overview about how climate change, the burning of fossil fuels, and other environmental manipulation has direct effects on health and indirect effects on health, just to kind of orient us. Direct effects on health include air pollution. We know that also we have extreme weather that could be floods, droughts, storms, extreme heat. That's going to be something really, really important for you in Phoenix. And then indirect effects, including disease spread, hunger, and decreased quality of life. So here are a couple of kids that have been affected by this. This is Ella Kissy Debra. She is the first person in the world to have air pollution listed on her death certificate. She lived in the South Circular area road near the South Circular Road in London. And when she moved to that area, she started experiencing extremely difficult respiratory distress that was called asthma. And much of that was air pollution. So she had air pollution listed on her death certificate. We know that extreme heat affects, this is Imani Bell, and she lived in metropolitan Atlanta, and she died during extreme heat during one of her sports practices. This is Lobsang. He died of extreme precipitation in Queens, New York, when his garden apartment flooded very precipitously. This is Zachary. He died in metropolitan Atlanta after a tree fell on his house after extreme weather. And these little twins also died during Hurricane Helene. They're the youngest people to die. They were only 1 month old. Then we know disease spread is also really, really important. This is a Vibrio vulnificus infection that has been seen, especially in Florida and the eastern seaboard, because of the warmer waters and flooding that have occurred. We know that there's decreased quality of life. There's a movie that's called Katrina Babies, and it tracks what has happened to the people that were affected by Hurricane Katrina back in 2005. And it really is profoundly affected their lives. And then we know that there's hunger, and then there's also mental health issues for both people who experience extreme weather, but also for kids today who are just worried about this. They're hearing about this on the news, and people are not talking about it. So they do experience mental health issues from this. So I wanted to just talk a little bit about infectious diseases. We know that over 1 in 4 children are exposed to vector-borne diseases like malaria and dengue in the world. We know that 1 in 7 children are highly exposed to flooding, predisposing to diarrheal disease. So that's not something that we talk about too often. And we know that climate change is going to be integrally tied to respiratory infections as well. When we burn fossil fuels, we should be thinking about not only global warming, but also air and chemical pollution. These are materials in the environment that result from human activity that endanger health. So we also know that they are connected. So extreme heat and fires leads to air pollution. We also know extreme weather can exacerbate ground level ozone. And so these are kind of integrally tied. So you want to be talking about air pollution and global warming at the same time. This is from the American Academy of Pediatrics, and they do a really nice schematic of how air pollution affects really everybody from the cradle to the grave. It affects all of us. We know that it can be associated with low-term birth weight, intrauterine growth restriction, childhood outcomes like asthma, autism, obesity, and then adult health impacts like cardiovascular disease and cancer. And then this is on the right from the Journal of the American Medical Association. And it was a paper that talked about what happened during the Olympics in 1996 in Atlanta, where I'm from. And it talks about how we actually had much decreased driving during a 2-week period of the Olympics. And they did traffic counts, and our traffic counts went much, much lower. And they measured air pollution in the air in metropolitan Atlanta during that period of time. And they saw ozone in particular was specifically lowered. And we also noted that pediatric asthma fell by 40% and non-asthma events was unchanged. So we saw really, really specifically how asthma was critically related to air pollution in 1996 during the Olympics. I just wanted to also give you a little bit of a flavor about what climate anxiety prevalence is occurring in young people. On the left is a survey of 10,000 people between the ages of 16 to 25 across the world. And they asked them, how worried are you about climate change? And really, you can see that 75% are in the orange or red here, worried about climate change. So if you think that is only in other countries, on the right is another study which looked at children in all different states across the United States, and there's all very, very similar data. But about 20 25%, 20 to 25% are extremely worried about climate change, how it impacts people and the planet. So this is something that young people are worried about. And these are 16 to 25-year-olds. They're also going to be part of our workforce here, especially even in healthcare. So I think more and more healthcare workers are also worried about climate change. And I wanted to give you also an example of climate anxiety. This is in my town. This was during COVID. So it was a town meeting talking about clean energy goals in our town. And this is what this 12-year-old was talking about.
I believe that adults take no initiative into protecting our climate and future generations. And that all the pressure is put on future generations to turn this world around. And I don't know if we can do that without y'all. So I just want to say that I hope that we as a community can work together to do the right thing and get through this together. Thank you.
I wanted to give you that example because I think one of the things that we need to do is we need to start talking about what we are doing to combat the climate crisis so that children know that we care about their future. We don't care about them only until they turn 18. We care about their future. This is a really nice podcast. It's called the Anti-Dread Climate Podcast, and they interviewed kids in two different schools. One school was where they really weren't talking too much about climate and sustainability, and the other was they were kind of teaching them about composting and about other things that they could do to help with the climate crisis. And you could hear such a difference in the attitude of the children. Where they were talking about this, they had so much more hope. So talking about this and telling kids what we're doing is in and of itself, to me, a climate solution. So what we want to be doing is moving from the concerned to the taking action area. If you do look at Yale Climate Communications, they interview people all over the country. And really, in red states and blue states, people are concerned about this. So we need to be moving from no to low action to taking action. And then I'm also going to encourage you to try and work on not individual change, but system changes, mini systems that you are a part of. Because one, you can work with other people, you can make bigger changes, and it's more fun. Honestly, it's kind of depressing to like think about this only doing this on your own because it is a really big problem. So we as healthcare workers can get involved in different ways. First is education. We can educate our patients. We can educate the public. We can work with schools. We can do undergraduate medical education, graduate medical education. All of that is really, really important. We can educate our government leaders, which I do think we have a huge role for. We can also try to adapt, kind of thinking about adaptation and resilience in the same category here. That would be, I've encouraged teams in August in Atlanta to start practicing in the morning rather than the evenings for, cross country or something like that. We also know that healthcare resilience, like we have to think about our supply chain. We need to be adapting to be expecting that there will be supply chain interruptions because of extreme weather. We also know that there's advocacy for solutions at the hospital, local, state, and federal level. Some of that is education. There are many, many states, including in Arizona, that have climate action groups. And I'll give you that information for Arizona. This is our Georgia Clinicians for Climate Action Group. And then we can also work on being healthcare resource optimizers, or I'm going to call that a hero, healthcare resource optimizer. That's healthcare sustainability, decreasing the greenhouse gas footprint of healthcare delivery. What does that mean? So we've used the word stewardship, using resources wisely idea, which is kind of like how Alexander Fleming saying in the 1940s, the thoughtless playing with penicillin leads to penicillin-resistant organisms, to a sustainability mindset, which is preserving resources for the future. This is Oren Lyons from the Onondaga Nation, who says that we should be making our decisions on behalf of the 7 generations coming so they may enjoy what you have today. So that is actually, it's expanding on stewardship to think about all the resources that we use in providing healthcare. Healthcare in the United States, the healthcare delivery system accounts for 8.5% of US greenhouse gas emissions. So let's start thinking about this is that our services lead to healthcare pollution, which is a social determinant of health. That leads to disease, which requires more healthcare services. We can interrupt that cycle today. And I'm going to talk about a lot of examples of that pretty soon. I just want to give you one more example about how this is so important. If you think of the estimate of global greenhouse gas emissions from healthcare, it's about 5% of global greenhouse gas emissions, and about 25% of that comes from the United States. So we have an outsized contribution to the greenhouse gas emissions from healthcare delivery. In the United States, we spend a high amount on of our gross domestic product on healthcare. We also have the highest greenhouse gas emissions in healthcare per capita in the world. So we can interrupt this cycle every day with the things that we do. So Matthew Eckelman has done a lot of these studies, and he wrote this article in 2016, and he said, the disability adjusted life years from deaths due to preventable medical errors are about the same order of magnitude as those lost due to healthcare related greenhouse gas emissions. So why are we not paying similar national attention to the need for prevention of healthcare sector pollution, just like we are about medical errors? And I'm going to talk about high quality of care in medicine. Oftentimes, preventing medical errors is actually synergistic with doing sustainable healthcare. So let's just talk a little bit now about where do our greenhouse gas emissions in healthcare come from? So we can talk about, oftentimes in businesses, they talk about scope 1 emissions, scope 2 emissions, and scope 3 emissions. Scope 1 emissions in healthcare, we're going to say greenhouse gas emissions. It's not just carbon, because some of the things that we use are greenhouse gas emissions, like our anesthetics, methane that comes from landfill. Those are our scope 1 emissions are those things that are coming directly from our facility themselves. A great example are anesthetics. Scope 2 emissions are indirect emissions, such as the electricity that we purchase in order to power our facilities. And scope 3 emissions is the vast majority of what we generate. This is from our meter dose inhalers, our business travel, our energy use, well to tank, medicines, food and catering, manufacturing, waste, information technology. All of these things are considered scope 3 emissions, and we can really, really reduce those. The biggest single chunk comes from the goods and services that we and pharmaceuticals that we use every single day. And then kind of outside of our actual estimated greenhouse gas emissions, but something that we can affect, are the greenhouse gases that occur from travel of our patients to our facilities. So we can also impact that in how we deliver medical care. So these are the greenhouse gas emissions that we're generating: carbon dioxide, methane, nitrous oxide, hydrofluorocarbons. These are all the greenhouse gas emissions that are being generated directly or indirectly from the services and the things that we do every day. So I just want to stop for a second and just say, wow, that doesn't feel good. That doesn't feel good for us to say, why I'm a part of a system that is making kids sick. I don't really like that. I don't like the fact that I have to travel also. I'm kind of part of that system just by living my life. So I think some of the ways that we can kind of make this joyful is to move from the gloom and doom to mitigation solutions. So what are these solutions? And the way that I think about this is almost like a vaccination for the planet. It's a very different kind of vaccination. It's energy conservation, it's electrification, it's composting. For me, as an infectious disease doc, I am wired to think about source control. Source control is decreasing greenhouse gas emissions, and we can be a part of that solution. So there's some national efforts to decrease greenhouse gas emissions. The HHS has asked for us to prepare for disrupted services, to publicly track our scope 1, 2, and 3 emissions. And there is a climate pledge that hospitals can join to decarbonize by 2050. I don't know what the future of that program is, but right now, today, it does exist. There is a primer to decarbonize from the Agency for Healthcare Resource and Quality, and the Joint Commission also has a sustainability certification that hospitals can do. There's research money available. I just applied for a grant to try to operationalize this in pediatric hospitals. So there is some national monies that are available to try to decrease our greenhouse gas emissions in healthcare. There are also some organizations to help you decarbonize in your hospital. There's an agency, there's a healthcare organization, sorry, it's not a government agency, that's called Healthcare Without Harm. And there's a branch of that that's called Practice Green Health. And they actually look at these 11 areas to try to help hospitals decarbonize or decrease their greenhouse gas emissions. For those of you in practice, outpatient practice, you can use mygreendoctor.org, which helps you look at getting some of this sustainability practices into your staff meetings. So we just did a paper that looked at mitigation efforts in children's hospitals, where we just looked at the publicly facing data about what hospitals are doing. And in the box are things that the AHRQ is asking us to actually do, which is tracking our energy use, our vehicle fleet use, emissions, anesthetics, food waste, and scope 3 emissions. And you can see that most of our hospitals that are above 100 beds, so bigger hospitals, are not really doing very much in this area. And we also, on the left, just had a sustainability page, just talking about, climate and health and anything they're doing. And even us in the South, we're doing, less than 30% of our hospitals in the South are actually doing anything in this area. So this doesn't mean that hospitals are not doing anything. It means that they are not talking about it. But I would argue that actually speaking about this is in and of itself helpful to your communities to say you are doing something about this and why. That's an educational opportunity. We also actually look to see how many educational efforts, publicly facing educational efforts, are hospitals doing. Are they talking about air pollution, extreme heat on health, plant-based diets, climate change as a problem for children's health, or even just environmental sustainability for the public good? And you can see that most are talking about public swimming pool safety, but only about 50% are educating about climate change's risk to health. There are some hospitals that are doing a good job. This is the Innova system in Virginia, and they do a very good job about talking specifically about what climate change, how does it impact children's health, and they're very, very clear. Now, I want to move from education and some of the things that you do sort of on a system level to things kind of the nitty-gritty about what hospitals can do and what we as healthcare workers can do. So I like this mnemonic from the Providence Health System, and the mnemonic is We Act. So We Act stands for W for waste, E for energy, A for anesthetic gases and anything along the agriculture or food cycle, C for chemicals, pharmaceuticals, and medical supplies. That's the biggest single chunk of our greenhouse gas emissions, and T for transportation. I'm going to give you some examples of what systems are doing and also some examples of what healthcare workers are doing in their microsystems. And I want to just talk about how environmental sustainability is really synergistic with good clinical care. If you think about choosing wisely campaigns, this is really when we choose wisely, we decrease the goods and services that we need to take care of patients. That is synergistic with good clinical care. In the UK, they have a Center for Sustainable Healthcare, and what they do with their quality improvement projects is they actually look for the best clinical outcomes with the least social, environmental, and financial impacts, which they call the triple bottom line. And I've been trying to incorporate this into the quality improvement projects that I do now. Now, when we talk about the W, waste, we should be thinking about throwing away. Where is away? Away is oftentimes low-income communities, either in our country or outside of our country. Much of what we throw away are plastics, and plastics in our country are largely derived from fossil fuels. We are producing more and more and more plastic each year, and most of it is not recycled. We waste about 14,000 tons per day. Packaging is the single largest source, and there are now concerns that this is actually this term called microplastics, that this is actually potentially harmful to health. And I'll give you a couple of kind of studies that have just more recently come out. We know that when we make plastics, we need a lot of greenhouse gases to make that plastics. I'm giving you here at the top, like you have to extract the materials, hydrocarbon refining, all of that kind of stuff to make that plastic. And if you on the bottom is a schematic from somebody who said, hey, this water bottle, to make that water bottle, you needed that much oil. And to transport it to market and to make it, you needed that much oil. So where can we decrease unnecessary plastics? We can't take away all plastics. Plastics in the environment are generally broken down into smaller and smaller particles, smallest of which is nanoplastics. The term microplastics was coined in 2004, and there are concerns that microplastic leakage is going to be higher in the future. So these are some examples. It's from the journal Science about just like what are some of the data about microplastics. We know we find it in the ocean. We know we find it on Mount Everest. We know we find it in stool. Now we know we find it in our blood. We know that it is in testicular concentrations of dogs and humans and higher in humans. We know it's in our bodies in different concentrations. And I think one of the questions is, does it do anything bad to us? Well, this article from the New England Journal came out in 2024, which said, hey, we found it in excised carotid artery plaques. And these are the pictures of those microplastics. And by the way, the people that actually had those microplastics in their carotid artery actually had worse clinical outcomes 34 months after that resection than those that did not. So there's going to be also questions about the solid waste, much of it plastics, harming our own bodies. We also know that getting all the stuff in the landfill leads to methane, which is a potent greenhouse gas. So when we can reduce solid waste, that is a climate solution. How do we do that? Well, we've been working on pharmaceutical waste. Especially in pediatric hospitals, we throw away a lot of drugs that we prepare, we'd never give to the patient. We're working on identifying unnecessary solid waste from infection prevention. We're asking our infection preventionists to educate about when we do and we do not need protective health equipment. We want to use it properly and not use it when we don't need it. We want to try and decrease unnecessary single-use plastics. Can we optimize microbiology lab waste? I'll give you some examples of that. Ensuring only truly biohazardous material also goes into the bin. That's also a solution because we know that in addition to being landfill waste, but we also need to autoclave or incinerate that biohazardous material. We know that every inpatient day generates a lot of solid waste, about 5.5 kilograms from an estimate in New York City. We also know that IV to PO conversion is really helpful. When we change to oral conversion, you need a lot less plastic. This is about 4.8 kilograms of solid waste just from IV to PO conversion from a study in Brazil. We also know we also save a lot of greenhouse gas estimates from actually just saving inpatient days. So keeping patients out of the hospital wherever possible is a good healthcare sustainability solution. We know that we can work on optimizing when to use protective equipment and when not to use it. This is a study from the UK. They actually noted that people were not doing good hand hygiene, and they were wearing gloves to take a blood pressure on a standard risk patient, and they actually didn't need to do that. So they actually improved hand hygiene while they also decreased environmental waste. So that was one of their projects. Just on the right here is, this was an auger. That handprint is taken after a healthcare worker did a physical exam on somebody colonized with MRSA. This auger will select out for MRSA. So they took a handprint after that person did that physical exam. You can see MRSA on their hands on that auger. The same healthcare worker does hand hygiene, and then they take another handprint, and they do not see the MRSA on the hand of that healthcare worker anymore. Hand hygiene is a good idea to prevent illness And that is going to be even more effective than doing unnecessary gloves. You need to be doing hand hygiene. So a couple of other ways that people are decreasing solid waste. This is from Mass General. They just changed from disposable caps to reusable caps in their operating room. This is from Oregon. They got rid of their disposable stethoscopes and they clean this as a high-touch surface, and so they don't throw away hundreds of stethoscopes every single day. There are reusable pulse oximeters that are being done and can save money. So all of these just small ways that people are decreasing are practicing healthcare resource optimization in their microcosms. This is from Children's National. They did a change in how they deliver their drugs to the floors, and they actually decreased unnecessary single-use plastics, and they saved $30,000 every year, and they had 60% decrease in plastics for pharmaceutical delivery. So I'm going to just shift gears a little bit and talk about how healthcare sustainability and antibiotic stewardship are integrally tied and how they are actually really a good way to be a climate hero. So one, let's just talk about avoiding unnecessary antibiotics. So let's say we have a 6-year-old diagnosed with sinusitis. This was after 5 days of upper respiratory symptoms that were actually improving. They're prescribed amoxicillin for 14 days. They're given a liquid because they can't swallow a pill. The prescriber decides to give an extra 10 cc's in case maybe that amoxicillin spills. And at the time, there was an amoxicillin shortage. So the parents drive around, then they have to call back, then they get amoxicillin clavulanate because there's an amoxicillin shortage. So let's think about the problems here. The patient is diagnosed incorrectly. The drug is unnecessary. The duration is too long. The formulation convention necessitates extra drugs to be dispensed. We know that when we give a liquid drug, we have to give a dose dispensing device. So that's either a plastic cup or a plastic syringe. So you've led to plastics being in the environment. There's harms generated with the prescription, the plastic waste for the actual prescription, the paper waste, the energy to make the drug, the travel for the patient to get the unnecessary medication. And then if, let's say, they have excess amoxicillin or amoxicillin clavulanate, they dump it down the sink. We know that ends up in our waterways. That can lead to resistance. And in fact, unnecessary antibiotics are estimated just from 2014 to 2015 to be associated with the greenhouse gas emissions of circling the equator 14 times in a gas-powered vehicle. So just by avoiding unnecessary drugs, you are being a climate hero. Be a climate hero by ordering appropriate microbiology tests. So let's think about some of the ways a lot of different studies are coming out about how we can optimize blood cultures. We know we've had a blood culture bottle shortage. To send endotracheal tube cultures only when necessary, to send urine cultures only when necessary. And we know when we optimally do that, we actually save unnecessary drugs. I just want to also show you some of the stuff you need to actually do these cultures. That's what you need for an endotracheal tube culture. On the left is all the stuff you need to do the culture, and then on the right to do the susceptibilities, which our lab technicians and our microbiology colleagues spend a lot of time doing. So when we send the test only when necessary, we're also saving a lot of solid waste. We know that we have a lot of blood culture contaminants. Well, we have rapid testing to help us to say that this is just a staph epi, it's just a contaminant from a blood culture. This is the stuff that you need to actually be able to do that test. And there's an aluminum can there. That's the only thing that's recycled from that whole endeavor to tell you that's a contaminant. So we have really tried to work on only getting cultures when necessary. And I've actually noted that we've had less contaminants in our system. All of this microbiology lab waste goes into this bin. And what happens to that bin? You either need to autoclave it. In our state, we need to autoclave it under high pressure steam or incinerate it. And that leads to high emissions costs. So solid waste and energy are oftentimes integrally tied in a hospital. So when we think about waste and energy, we can think about them anytime we have a biohazard bin. They're both solid waste, but energy to dispose of that. So we actually estimated the greenhouse gas emissions associated with different cultures, a urine culture or a blood culture. Positive means the lab needed to work it up. And this is just for the disposal, not to make all these items, but just to dispose of them. So an endotracheal tube culture is about 0.4 to 0.5 miles equivalent of driving in a gas-powered vehicle. So just by saving these and thinking about optimal diagnostic stewardship, which saves unnecessary antibiotics, we can also save landfill waste. Another way you can be a climate hero is to change to oral treatment whenever possible. So in the UK, they use this model, sustainable healthcare value, best clinical options, outcomes with the least social, environmental, and financial harms. If you switch from ampicillin to amoxicillin, we know that there's been a couple of studies looking at community-acquired pneumonia that were presented last year from Colorado. You also save about 20 minutes of nursing time and or pharmacy time to prepare the drug and to deliver the drug. You save a flush that you need for an IV administration, and you save money. So it's a great way to save. And I really think we should not just be thinking about this with antibiotics. We've been working on IV famotidine. Can you go to enteral wherever possible? You will save a lot of solid waste. It's easier on your nurses as well. Nurses are overworked. They have to check the IV a lot. We know that can be associated with peripheral IV extravasations, and you can help your system. And when you think about the social benefits, one of the social benefits is all of the work that needs to be done by your nursing staff, by your pharmacy staff, by your environmental services staff as well. You can be a climate hero by placing timely antibiotic stop dates and using minimal safest duration. We noted in our hospital and many other hospitals, pediatric hospitals have all noted that we have a tremendous amount of pharmaceutical waste. We prepare the drug, it's weight-based. It goes back to the pharmacy because we changed the drug or they went home and it goes back to the pharmacy. And in our hospital, this is all incinerated. Think about all that plastic waste. We documented what drugs are we wasting. A lot of them are the drugs, antibiotics we use every single day. In the orange is the day of discharge. So just by putting in a stop date to tell people, hey, we don't need these drugs after this time, we can save a lot of unnecessary waste. And so we actually just looked in our hospital about, hey, this is when you need to put the stop dates in order to avoid waste. So one of the things that we've done in our hospital is for our community-acquired pneumonia, we put in an order set that just goes automatically from IV ampicillin to oral amoxicillin after about 36 hours. You can opt out of it, but that's just going to be the default rather than the default being IV until, hey, I'm just going to think about, oral now. I want to go over to energy just to talk about a couple of things that some systems are doing. The Gunderson Health System in Wisconsin, private system, they are producing more energy than is consumed from fossil fuels since 2015. Their renewable energy generation offsets 10% of their electrical usage, and they're estimated to save about $100,000 each year from that. The Cleveland Clinic, they adjusted their air exchanges in their OR to turn it off when the OR was not in use. Reducing their energy costs saves them about $2 million per year. You can also think about resiliency. This is a community in Florida. This is about 2 or 3 days after a huge hurricane reached that area. They had renewable energy, they had resilient buildings, and they were all able to go back to their home. When this is in Boston, the Boston Medical Center, they have an innovative clean power prescription program. They put solar on their roofs and they generate electricity and they give credits to people who have energy insecurity. And they are able to actually help them with their energy burden. They found patients that are, needy based on some social determinant of health screening that they do upon their admissions, and they help them with their high energy bills. Let's talk a little bit about anesthesia. I don't know if there's any anesthesiologists in the crowd today, but anesthesia has actually made a lot of strides in decreasing the greenhouse gas emissions from the fluorinated hydrocarbons that we use. So they can work to get the lowest, safest fresh flow gas rates. They can also work on what they did in Seattle Children's, where they actually removed desflurane vaporizers, which is a very potent greenhouse gas. They actually eliminated nitrous oxide in their hospital, and then they worked to give feedback on the lowest, safest fresh flow gas rates. And they actually decreased by 87% their greenhouse gas emissions in their operating room. And now they're actually doing this in a multi-center study. This is called Project Spruce. There's also ways to reduce the need for anesthesia. We know we need anesthesia a lot for radiology studies. So this is a study that was done from Lurie Children's, and they did a rapid MRI protocol for acute pediatric musculoskeletal infections. And they were able to, by doing this rapid protocol, they decreased the need for contrast, decreased sedation, decreased scan time, decreased interpretation time. They decreased hospital length of stay and charges to the patient. So this was a great sustainable healthcare value plan. We've implemented this in our hospital, and I've really noticed that we have very, very decreased times to be able to diagnose pediatric musculoskeletal infections. Going to the food cycle, agriculture and the food cycle. We can ideally use local plant-forward organic food. Plant-forward, less meat means less antibiotic-fed meat, means also less greenhouse gas emissions. We can optimize delivery to minimize unused food. We can divert unused food to the needy, and then we can compost because that keeps carbon in the soil instead of methane in the atmosphere. One of the hospitals in Atlanta is doing a partnership with a company, actually, who takes the liability from getting that food that would be otherwise thrown and getting it to people who need it. And they are estimated to have saved 10,000 pounds from the landfill in 1 year. We know that chemicals, pharmaceuticals, and supplies are another huge area. Meter dose inhalers have a greenhouse gas in the propellant. In Europe, they're actually trying to move a lot towards dry powder inhalers. But we are actually working on just decreasing unnecessary use in bronchiolitis. Albuterol and unnecessary albuterol for bronchiolitis, which is not recommended by the AAP, is also associated with greenhouse gas emissions. We want to be able to do smarter ordering of supplies. A lot of what we can do is try to work with our supply chain managers to try to order things. Some of the operating rooms are trying to say, okay, this is what I need in my kit. You have to have the surgeon involved in that. Eliminating low-value practices in the name of infection control. We are actually have moved towards symptom-based isolation. We do not isolate for MRSA colonization or colonization with an ESBL, and we are actually saving a lot in gown and glove use, and we've actually seen really good outcomes in our hospital because we have good hand hygiene. And then finally, T is for transportation. We can work on employee transport, carpooling, electrified ambulances, and fleets, patient travel, professional meetings. So I'm now making it an effort to really one professional meeting per year virtually for myself to say I can decrease my carbon footprint greatly by just doing that. We looked at our telemedicine and our infectious disease clinic. By doing telemedicine for over a 3-year period, which we were not doing at all before COVID, we saved our patients 31,000 miles of round trip travel. That's about 95 miles per visit because we're a subspecialty clinic. And we also looked at adverse outcomes and family satisfaction scores, and they were all really good. We don't do this with every patient. We screen the types of patients that need to be seen in ID clinic, but actually some of my hospital follow-ups I do by telemedicine, and I think parents are very, very, very grateful. So I'll say that the top 10 reasons to incorporate sustainability into your hospital's practices. You'll save money. You will retain your employees. The Commonwealth Fund just did a survey that 80% of employees want to work in a place that is doing something about climate. You will model to kids that you care about their future. You will have a more resilient healthcare system. When you decrease waste from the outset, when you reach a shortage, you will have a better way of dealing with that shortage. Using less oftentimes means less harm to patients. The Joint Commission may be asking you to do this soon. Right now, it's a voluntary certification and may become required in future years. Federal targets are not enough to reach necessary climate goals. We dropped out of the Paris Climate Agreement yesterday, so we need to step it up at the local level. You will attract trainees. You will conserve employee time, and it's the right thing to do for the health of our children. Oh my goodness, why is this not advancing? Okay, so just a couple of quick reminders: decreasing unnecessary IV medications, putting in stop dates, telemedicine, vaccination, keep kids out of the hospital, keeping diagnostic stewardship, all climate smart healthcare. I want to just talk a little bit about advocacy. I think when we talk about advocacy and education, we dream of a future we're set, the world should be decarbonized by 2015. That's what the scientists are telling us. We should be having by our greenhouse gas emissions by 2030. But we need some explicit steps in there. We need to start talking about this, and we need to start doing this in our microcosms. When we think about socio-technical change, we need to work on all of these things: infrastructure, processes, and procedures. Talking about this, we need to work on all of it. There's some advocacy that has been really, really effective at the hospital level. This was at University of Pittsburgh, where they just did a petition and they got their leadership to start integrating sustainability. And they have a really nice sustainability program at UPMC now. They were on the radio as well for their efforts. There are also organizations you can join: the Medical Society Consortium on Climate and Health. I'll be going to that meeting in March. Healthcare Without Harm. And then also we have a sustainable infectious disease group called Sustainable ID that I helped to co-found with Shreya Doshi, who's really done a lot of work in this area. Some people are just actually encouraging their patients to vote. The Vote ER program, it doesn't tell you how to vote, it just tells you, it asks patients to vote. And when patients are asked about this, they actually feel cared for when we ask them to and encourage them to vote in any election, large or small. There's a sustainability conference that's going to be in Atlanta this year, if anyone would like to come. That's called Clean Med, and that's all about healthcare sustainability. There's the CHOF Fellowship through Harvard, where they actually help you do some social organizing about how to get your projects off the ground. I did this program and I would highly recommend it. In Georgia, we're working on trying to advocate for electric school buses to decrease air pollution, which is also a greenhouse gas emission solution in our state. Then there are a lot of different partners that you can work with. So I can leave you some resources. So the most important thing we can do is to talk about what we're doing, to encourage our constituents, not our constituents, our patients to vote. You can use Vote ER here, and some of our programs in Georgia are just encouraging their patients to vote. This is the program that we're doing in Georgia that's called Healthy Air is Healthcare, for advocating for electrification of school buses. And then finally, I want to leave you with a couple of tools to help you think about what you can do. This is from Ayanna Elizabeth Johnson. It is a Venn diagram. And that Venn diagram is the intersection of three circles. What are you good at? Or I would say, what are you doing every day? What brings you joy? What work needs doing? A lot of what I'm showing you is what I have done, because this is the integration of what I'm doing in antibiotic stewardship and trying to decrease greenhouse gas emissions. So think about these things, about what you can do. What not all of us are going to do the same thing. We need to have an army of people working on a microsystem to decrease greenhouse gas emissions. So I will leave you with this quote: do not be daunted by the enormity of the world's grief or climate change or antibiotic resistance. Do justly now. You are not obligated to complete the work, but neither are you free to abandon it. These are all mosaics of the Mona Lisa. And you can see the difference in these mosaics is that there are more tiles on the right-hand side than the left-hand side. The more of us that are working and encouraging each other to change a microsystem, the more progress we are going to make. And when you inevitably feel like giving up because it seems so big, think about who is watching you. This is my daughter and my mom. And I just see her looking at my mom. They are watching us. They are watching what we do. If we say we will do anything for our kids, do they believe us, or do they think, no, they won't? They're not doing anything for my future about climate. So when you ponder quitting, pay attention to who is watching. I do a lot of this work for my family, for my kids, for my patients. And I just want to encourage you to think about the people that you love when you think about this work. So I also just want to leave you with my email in case you have any questions. And then also I looked this morning at the Arizona Health Professionals for Climate Action, which has a really nice website. They look like they do a lot even with healthcare sustainability. So I would also encourage you to check out their work that you can do in your own state. And I thank you so much, and I would be happy to take any questions.
All right, that's awesome. Thank you so much. I mean, I can see from, the people in the room and, looking around at all the ideas that you presented, and that it's always eye-opening whenever I hear you talking about this. There are a couple of questions. I'll start with the questions that are in the chat. And the main one was, the first one was, does the US News and World Report or other organizations that rank healthcare systems give quote unquote points for climate improvement interventions, because sometimes that obviously can influence practice?
Yes, I love that question. And I actually wrote to US News and World Report. They have an email. And I actually got a reply that, they're trying to they said that they were interested, but they actually also feel like that their role is to try to guide patients about where they can go for the best medical care. So actually, I'm thinking about advocating for kind of some sustainability measures that integrate very nicely with patient safety. I do think that is a great avenue, and I do think we need some advocacy in this area. So stay tuned on that. I think we're going to try and do some of that work through the Medical Consortium of Climate and Health, because I do think that's a really good lever to pull. If there is a federal action on this area, we can work with Joint Commission, we can work with US News, and I think those are two great areas.
Perfect. The other reminder for everybody here at Phoenix Children is that actually in September, through the Pharmacy and Therapeutics Committee, we passed an interchange protocol for intravenous to enteral therapy. So this is basically a policy that gives the pharmacist the ability to make the automatic change if patients, fulfill some of the criteria. And that list of medications, you can check that policy on Index. And that, list of medications includes not just antibiotics, it's mostly antibiotics, but a lot of the other stuff that Dr. Jaggi talked about, including famotidine and some other medications. So I really encourage you to actively think about that during your rounds, but also know that in the background, we're working on making this as an automatic change. The other question that I had actually is related to infection prevention and control. And our infection preventionists actually, are aware of this topic, that because I always like to bring it up, which is the contact precautions for MRSA colonization and ESBL colonization. So I was hoping you can share your experience about when you made that change. Obviously, that can lead to some anxiety in terms of, abandoning some of what we think are protective measures against transmission, and how maybe the focus should be shifted mostly to improving hand hygiene if there's any problem around that.
Yes.
I don't know if you have any tips or kind of comments about this for everybody to hear.
There's a couple of really nice articles that have come out about this. Priya Nori, I know, was one of the authors on something that came out in Clinical Infectious Diseases. And I do think that there is a large differences in many hospitals. A couple of centers like LA in an adult, in their long-term care facilities, they're looking at both environmental waste and transmission of MRSA, and finding really like that really doesn't make any difference. And so I think that, the official CDC guidance, I don't think has changed yet, but there are many centers that are going towards this. So there are downsides when you do gowns too, in the sense that people don't go in the room. Are you doing as good of hand hygiene as you should be? So we have moved towards, we have not seen any increase in our MRSA rates. I was not actually the one responsible for this. It was my colleagues, Dr. Shane and Dr. Lynham, who were actually just doing it they were actually thinking like people aren't going in the rooms and is it necessary? So they weren't thinking about it from a sustainability mindset, but it's worked really well in our hospital. So you'll see some differences in different hospitals, but hand hygiene is the most important.
Yeah, absolutely. So just a reminder, we still are, at Phoenix Children's still, implementing the contact precautions for those two, groups of pathogens, but pretty soon we may see a change about that. So don't change your practices yet.
You have to go, I think every protocol change, you have to go as a group. You don't want to do
Right.
one-offs. Don't do that because it's,
Yeah.
I just think from a just getting things going standpoint, it's very confusing too. So you want to go with your protocol at your hospital.
And in the chat, I put in the website address for the Arizona Healthcare Professionals for Climate Change. So obviously this is, one way we can start working on this here in Phoenix, but there's obviously a lot of ideas that we'll be happy to partner with everyone at the hospital to start working on from a sustainability standpoint. I don't see any other questions. Unless someone in the audience, I'm sorry.
And we're at time.
Yep, and we're at time. So thank you so much. That was great. Always good to see you talking about
Always
this.
good to see you. Thank you so much. And if anyone has any questions for me, you can give anybody my email. I'm happy to help kind of give you any ideas on any projects.
Okay, and one more announcement. Starting with this grand rounds, for those of you who are board certified pediatricians, we are trying to get it worked out that you get an MOC Part 2 point for every hour that you get an CME credit. So if you're interested in that, there should be a quiz that you have to take, just a one-question quiz, and that will get you the point. So we're experimenting with that right now. So if you're interested, go ahead and try it and see if it works.
All right. Thank you. Have a good day, everyone.
Bye-bye.